Thank you all for coming. This is a Kellogg College seminar, but as you might expect from Kellogg College, if you know Kellogg College, it is open to all. Kellogg College, until quite recently, was proud of being the youngest college in Oxford, but first Green Templeton tried to steal that crown from us, and now the new Cox College is definitely going to take that crown from us. Kellogg College has been going for under 30 years, I think. It's closely linked to the Department for Continuing Education, but not uniquely. We have full-time students and full-time staff as well. I'm Richard Stevens. I'm a fellow at Kellogg. Our speaker today is Dr. Christian Roman, who is, which category are you at Kellogg, Christian?
I'm a research member of the Common Room.
A research member of the Common Room, thank you. Yes. But I also know Christian as a colleague of many colleagues. I know the Biomedical Research Centre, as many of you do, and the Institute of Biomedical Engineering in particular, as one of those Lionel Tarasenko organisations from which so much exciting research in Oxford is coming. And I notice in the attendance list that this has brought in people that we know from all over Medical Sciences Division, as well as engineers from outside Oxford, physicists and other disciplines. Okay, Christian, would you like to start?
Thank you, Richard. Thank you for the introduction, also for the background on Kellogg. Thank you, Kellogg, for the invitation to present today. I've been a Kellogg member now for around 3 years, and it's great to be able to present some of the research within this environment. Before we start, I'd like to mention that I feel very fortunate to be able to present some of the results of this interdisciplinary work on which many people have contributed over the past few years from both the university and the hospital. As you mentioned in your introduction, this is a highly interdisciplinary work between engineering and the medical divisions of the university. The talk today is about the wearable technology during COVID and how we managed to support the NHS during the first, from the start of the pandemic. The talk is scheduled for approximately 35 minutes to allow enough time at the end to ask questions and also exchange ideas. It is mainly split into 3 sections. The first one is an introduction on the work that we have been doing that has allowed us to be in a position to help the NHS in March 2020. The second point is the system that we introduced, which is the Virtual High-Dependency Unit, or commonly called the vHDU, with a probably risky but hopefully rewarding demo at the end. I am currently monitoring my vitals right now, as if you look at the camera, I am currently wearing a finger probe, and I'm also wearing one of the patches that consists of the system. And we'll be able to analyze some of the trends to see if, and decide if maybe they're due to stress or enthusiasm as I present through the different sections. The last part is future work and some ideas of how the system might be improved, or how or the direction that this might take in the future, and to exchange ideas with the audience. So, as mentioned in the introduction, I'm a postdoctoral researcher at the biomedical signal processing and mHealth group, led by Lionel Tarasenko. The group expertise consists of machine learning and signal processing of various types of data, either continuous or more sparse, such as ECG or blood pressure readings, respectively, with the objective to provide useful insights for clinicians to make better informed decisions, either for diagnostic or treating patients. There are 2 streams of work that this is being applied to. One is primary care and one is the hospital. In primary care, we have home monitoring and self-management of chronic conditions. These can involve hypertension, prevent this, the occurrence of a second stroke or hypertension in pregnancy. We've also applied some of our expertise in gestational diabetes and chronic obstructive pulmonary disease, most commonly known as COPD. Usually these applications involve apps on Android and iOS, where the participants input data or input values, and then the systems provide back feedback on the next action to do. The hospital side consists of vital sign monitoring, of alerting and automated screening. And two of the example projects that I've placed here, one is the non-contact vital sign monitoring, which is led by my colleague Mauricio Villarreal, where cameras are used to detect heart rate of patients, and the Virtual High-Dependency Unit, which we're going to talk about today, and which was implemented during at the start of the pandemic. There is a third section where we try to bridge the gap between the hospital and primary care. And one example of that is in the detection of hypertensive patients in hospital, that they can then be referred to their GP or to their local practice for appropriate treatment. So today we will focus on the Virtual High-Dependency Unit project, and what is its aim and objectives. So the aim of the vHDU is to demonstrate how high-risk patients can be monitored and managed on a general ward using wearables and smart alerting algorithms. And to understand this a bit better, I've selected a scenario. So if you imagine a patient that is sleeping in the ward at 4 in the morning, at 4:40, this patient deteriorates and becomes blue. So their oxygen level in the body drops. At 6 o'clock, when the first round or when breakfast is being served, then the nurse notices that there's something wrong with the patient because they're blue, and will get an appropriate monitor to try and see what is wrong, and will identify what is wrong probably 15 minutes later. So we have 2 hours, and in this scenario, 2 hours and a quarter before the patient is being treated. If we have wearable devices in the same scenario where the patient is sleeping at 4 in the morning, and if there are wearable devices attached to this patient, at 4:40, when the patient becomes blue, an alert is being triggered via Wi-Fi or any other proprietary wireless algorithm that is then shown at the nurse station at 4:42. At the nurse station, the alert is being propagated to the nurse, so that at 4:44, the patient could be provided treatment, and there's an early recognition deterioration with a fast intervention. So in this specific scenario, 1 hour and a half can be gained by having these wearable devices. Another advantage of using wearables is that clinicians might get a picture of a patient's health over a longer period. If we assume, if we assume that the patient admission is at the blue arrow, and if we assume a standard case where the patient is neither deteriorating too much or requires too much attention, then probably the vitals will be collected every 4 hours. And if we have the monitoring, the wearable monitoring, then we might get we might get the vitals and the trends every 5 minutes. Now, still prior to COVID, the project had tested the wearability and accuracy of a number of CE-marked and FDA-approved devices to record ECG and monitor heart rate, respiratory rate, and oxygen saturation. And it's possibly because of this SpO2 or the oxygen saturation that we managed to put the system onto the COVID wards. The accuracy of the SpO2 measurement has been tested in a hypoxia study with volunteers against the gold standard, which is the arterial blood gas measurements. So what is an hypoxia study? In the hypoxia study, we took multiple wearable devices that were on the market, and we've placed them on healthy volunteers, on participants, and we decreased their oxygen level in a very controlled environment until they reached around 80% in their blood. So on the right side, you will see the clinical setting with the hypoxia study day setup with number one, the tablets linked to all the devices. Number two, the resuscitation trolley and oxygen. Number three, the oxygen nitrogen cylinder, the hypoxicator as number four, the Philips monitor, which is a standard use in the hospital, and then number six in the top right corner, the drip stand with the arterial line pressure. As an example scenario, the participant is at 100%, has 100% blood oxygen saturation to start with, and gradually their blood oxygen drops, and we see in this case that both the Philips and the device follow a descending trend. The stars that you see on the graph are the arterial blood gas, which are the golden standard. So in this case, the RIST-02 3150, which is the non-in, actually underestimates a little bit of the oxygen level. For a value of 90, it will probably output 88%, which is better than overestimating, which would show that the patient is actually in a better state than what it actually is. So the selected devices for the vHDU were the non-in pulse oximeter that you see here in the left side image, and the vital patch on the right side of the image. The vital patch is a product of Vital Connect, a company we've been collaborating with, and both these devices are connected via Bluetooth to an Android tablet. When choosing these devices, not only the accuracy was important, but there was also considerations about the wearability of these devices. It was no use if a device was extremely accurate, but it would switch off if the patient would take the finger out of the probe and would not turn on automatically when the finger was put in the probe again. So the advantage of the non-in is that it has this capacity of automatically detecting when the finger has been placed into a probe and automatically switching on, and it also has a battery duration of 48 hours, which allows enough time for constant monitoring without having to swap the batteries around. One disadvantage, depending on how we look, is that it does require batteries that need to be changed every 48 hours, but it is a fast process. On the Vital patch side, or Vital Connect, it is extremely wearable and non-invasive. It's being placed on the chest. It provides ECG, heart rate, and respiratory rate. The batteries are included into the patch, and it is a single-use device. This single-use device provided an advantage at the beginning of the pandemic, as it allowed for better infection control. Given that we've selected these two devices, I want to show a little bit the precision at which these devices monitor data by showing the Bland-Allman plots. The Bland-Allman plots evaluate the mean bias and the limits of agreement for both the non-in and the vital patch. So we have the non-in at the top and the vital patch at the bottom. We can see that the non-in undervaluates by 1.92 for the SpO2, and for the pulse rate, it is quite close to the gold standard. The vital patch is also very accurate in both heart rate and respiratory rate. So what was the situation at the end of February? When we've been hearing about COVID and the pandemic, and late February, there were some discussions about placing this project on the isolation ward in the John Radcliffe Hospital, as it could easily be adapted from what we currently had to a solution that could run 24/7 with a nurse dashboard that we didn't have at the time of the hypoxia study. Why was this important? The wearable monitoring allows patients to mobilize, particularly useful in respiratory disease, maintaining monitoring while reducing staff overload. And it also allows the nursing staff to observe their patients without entering their rooms on the isolation ward. At the beginning, the situation wasn't very clear on how infectious the virus was, and it provided a good application. I would like to show on which COVID patients this has been applied, or where the vHDU system can be used. There are three types of COVID patients. The first group is the asymptomatic or the mild symptoms. These are the ones that can isolate at home. Then we have the intermediate group, where patients are in isolation rooms either under observation that might require oxygen or that are recovering from intensive care unit. And then we have the severe patients that do require intensive care or that are in a different high dependency unit. The intermediate and severe groups are at the hospital, and the vHDU is only applied on the intermediate ones that might require oxygen and that are under observation in the isolation rooms. What were some of the challenges? As I've mentioned, we've had to make a balance between wearability and accuracy. If a device would not turn on when the patient was removing and then placing the finger back in the probe, and it would require constant attention from the clinical staff, I think it wouldn't have provided the required performance. Infection control was another aspect to look at by placing all these different devices at the beginning and deciding if they're going to remain in the room or swapping them while the patients are being discharged and other patients being readmitted. And then in the design of the nurse dashboard, there was this risk of drowning the clinical staff in data. So there was a big effort of a user-centered design in order to provide information which is as concise as possible and that can provide useful information. I must mention now, and I will touch on it a bit later as well, that the system, although has the capacity of alerting, did not alert on the COVID wards. It was simply used to show the vitals, the heart rate, the respiratory rate, and the SpO2 on the dashboard at the nurse station. The timing also provided a few of the challenges. We had approximately 3 weeks to adjust what we had to implement a new system on a ward, which even in normal conditions is quite challenging. But the staff have been very welcoming of the system and have provided very useful feedback from the start. Then there was the training and support provided by both the engineers and the clinical team, which consisted of 1 hour of training every couple of days for the first few weeks, and then continuous support afterwards, even though more intermittent, just to make sure that everything's working fine. One point that we focused a lot of time was to make a system that is 24-hour reliable, and that requires no intervention from any of the clinical staff on the ward, so that it doesn't present an extra burden. And that is an automatic failure recovery. If the system notices that it fails either on the tablet, it will automatically recover and restart without any input from anyone. And there was some concern with the demand for wearable devices, especially for the SpO2, as everyone was trying to buy them. Luckily, we had a stock that we were using for the hypoxia trial, and that we were planning on using for the subsequent trials in the vHDU that we were able to use. And we did also manage to order multiple ones later on. Although there were these challenges, the system did go live with its first ambulatory patient on Monday, 23rd of March, and up to April 15 this year, it has been part of normal practice for 165 patients. So what is the system? The system is mainly composed of three parts. The first one that we've discussed is the tablet, which is placed at the bedside monitor with the vital patch and the SpO2 that streams data to the tablet. The second one is the back end, which is all sitting in the OUH and servers, so on the John Radcliffe hospital IT system. There are two streams coming out from the tablet. One is the streaming service, which goes directly to the nurse station to provide information as fast as possible, and the other one going into the web service, which then stores all the data in databases and the file system. Another big advantage is the integration of the system with the hospital network, where all these vital signs observations, the 4-hourly, for example, that I mentioned before, taken on send, are being fed into the vHDU system, and a uniform chart can be seen by the clinicians. The third section is the Clinician Dashboard, where they can see all the patients and all the live vitals from the tablet, but also the messages that come through send. A few details on the patient tablet. The design was tried to be as clean as possible, with the information of the connected wearables at the top. We have the vital patch and the non-in, and then just below the MRN patient that the nurse can easily remove and add by clicking this button. We have the ECG from the vital patch and the plot from the SpO2 and the different vitals that we connect. The skin temperature on this version of the vital patch that we used at the time, the skin temperature was provided. On these newer versions that vital patch have provided, we do have the body temperature. However, with the previous version, we only had the skin temperature. The early warning score was computed but not shown. And we also had the position of the patient, either standing, laying down, or laying back. The patch also provides a number of steps for the patient that the clinicians can use to see if the patient has been mobile across multiple days. And now we've reached the patient dashboard with the live demo. Hopefully, yes, everything will go well. We've left all the bad luck behind us now. I will just exit presentation mode, and I will try to bring this one here. So for purposes, I will just increase the size a little bit. These are the different cards that the nurses would see. Each patient would represent a card.
Christian, forgive me. Could you zoom in a little further? If
yes.
That's not...
Sorry. Yeah.
Thanks.
Is this better? Yeah.
Great.
So we have a card for each patient. In this case, Data Storm is a past patient that has been discharged 5 hours ago, and I am currently monitored as Kellogg Seminar on the right. As you can see, my heart rate is a little bit high at 140, but my respiratory rate is quite good. My SATs are within the good parameters, and my temperature is at 37. You could also notice that I'm standing with the total steps of 5,000 since I've placed dispatch yesterday evening. Let's say half acceptable, the number of steps. If I try to lean back, although it's not yet time to relax, I will get lean back here. That is being output. The clinicians can go into the patient viewer and they can click on seminar, okay, and they will get a live view of the ECG and the pleth that is being streamed directly from the tablet, with the vitals being updated on the side and any send information that is being received at the bottom. In this case, given I have not connected this user to our simulation data, we do not have any send information. Now, if I do move the probe a little bit, so you would see all this noise being accumulated on the pleth. And this is something that the clinicians can also observe if the patient is moving or if the patient is just quietly wearing the probe. There is a third view which the clinicians found useful, and that is the vitals chart, which is a combination of vitals. I've modified the algorithm in this case to provide updates every minute from the tablet rather than every 5 minutes in order to have a little bit more data. So we've noticed that we've started, this is still on the on the UTC time. It doesn't switch to British Summer Time unless I'm local. We started at 7:30, and we can probably notice that this trend here is when we had those problems with PowerPoint, but I have briefly recovered since. And now that we're talking about the presentation, my heart rate has been going up. So these are some type of the trends that one can notice over time. My temperature has been constant, and if we click on a different column, we will get the specific values on the right side of what we clicked on the column. I will show you another example with data that is being simulated from SEND. So this is what would be seen if a participant would have, a patient would also have SEND observations. These are observations coming from the hospital, and then the nurse would be able to click on them and see all the details that are needed. A combination of the two is on this graph. Although there is no alerting, you will notice the small Bluetooth sign at the top, which indicates that these vital summaries come from the wearable devices. When there is no Bluetooth sign, this observation comes from the hospital. And with this, I think I will switch back to the slides. We can get back to this if needed at the end. So to summarize at the patient dashboard, the main point is that it has a secure access. There's a real-time data display. It's been integrated with the hospital system, and it has a built-in alerting system. However, this built-in alerting system has not been used for COVID. What are the results? So over a period of 389 days, from the 23rd of March up until the 15th of April this year, we've had 165 patients. The most patients that the system has simultaneously monitored was 12. And we've had continuous data for 7,752 hours, which is equivalent to 323 days. This continuous data assumes no gaps. So it is data concatenated from all the patients with no gaps. The median monitoring per patient is of 24 hours for the entire duration. This is calculated from the time we first had a point until the time we last received a vital sign for this patient, again, with continuous data and no gaps in the data. If we are to compute the hours of continuous data over the equipment wear, we get an 87% median of when these patients were wearing the system. So you might wonder why weren't they monitored for more than 95%? It might be that the system crashed for a few minutes, or if they might have had a shower, or they moved away from the patient bed such that the connectivity did not work. This graph shows the peaks that match between the vHDU patient usage on the left, which is also the blue line, compared with the Oxford University Hospital admissions, which is on the right. So it's a two-axis graph. And as the number of admissions rose in OUH, the usage also increased of our vHDU system in both waves. So we have the first wave here in March, with the second wave in December and January, or depending, second and third wave, December and January, just here. What are some of the usage observations that we've seen? Is patient acceptance of the wearables. The non-in and the probe, wearing it for longer periods of time might make the finger a little bit moist and can be uncomfortable. So some patients were taking the wearables off at times, but they would either put it in later or when indicated by the clinical staff. So that is also some of the explanations for the percentage of time that we have data for over the monitoring period. And on the case of the vital patch, although on very rare occasions, some patients would not feel comfortable wearing such a patch and would just remove it after a few hours of usage. The application over time also changed. Although at the beginning, the system was being placed on almost all the patients in the specific ward, we've observed that gradually it's been used mainly on patients that required oxygen, as it allowed the clinical staff to have a better understanding of which patients are having their nasal cannula connected. So in the first wave, we have a median monitoring hour of 31.5 per patient, and this decreased to 24 if we combine both waves together. And this is because the system has been used in more and more specialized situations. Some of the NHS staff feedback, where the system was a delight to use. It allowed the nursing staff to observe their patients without entering the rooms on the isolation ward. It therefore reduced the exposure of staff. Doctors found the ability to review data useful to determine trends by looking at the vital charts that we've also had a look at. and the system continued to be used until mid-April 2021. Some of the future work involves the different alerting strategies that we need to put in place, and that is quite a challenging situation, as we want to avoid alerting fatigue. And one of the clinical trial that is being scheduled is to test these alerting strategy. Then there's the home monitoring aspect of the system. Can this system be used potentially before the admission to the hospital or after a patient has been discharged to make sure that they're not deteriorating further when they're at home? And the third aspect is to remove the one tablet per patient limitation, meaning to remove the tablet being placed at the bedside, but rather a larger infrastructure investment on having these gateway receivers across the hospitals that patients in non-COVID times would be able to roam around the hospital freely, and their vitals would still be connected. Before we jump to the Q&A session, I would like to acknowledge the nurses and doctors on the COVID-19 wards and the confidence that the Oxford University Hospitals Trust has placed in this project, along all the members from the Biomedical Signal Processing and mHealth Group and Critical Care Research Group. We've collaborated very well over the past years, and that has allowed this this project to be used. And I think that is it, with a little bit of delay due to the problems that we have, but hopefully that gives us still enough time to take some questions.
Christian, that was an excellent glimpse of the future of nursing, maybe. Could I invite people who would like to ask questions, please would you put your camera on if you can? That's a nice relaxed way to ask questions. Christian, do you want to stop sharing for the moment?
Yes.
For those, if you can't put a camera on, maybe you're on the bus or maybe you just don't have a camera, then type in the chat window and I'll relay your question to Christian. But in the meantime, Ludo van Every, what's your question for Christian?
Hi there, I should address, of course, I'm not Ludo. My name's Nadia, hi. I was just wondering, your alerting strategy, is that a sort of deterministic case of somebody's gone beyond some clinical limit, or is it more preemptive, looking at, oh, there seems to be a change in the data generating process and this should be looked into?
That's a very good question. So I think it can be both, depending on what strategies we want to apply. We can apply simple thresholds on which we can alert, similar to the example I gave with the small patient deteriorating at 4:40 in the morning. Or it can be a multivariant problem where we notice that multiple parameters are on a downward trend, and we try to predict when that patient is going to be in a bad state. So I think both strategies are looked at.
Great, thank you.
We must take a moment to congratulate you, Christian, on your courage in doing a live demo. And the fact that in the event it wasn't your software or hardware that let you down, it was Microsoft PowerPoint.
Exactly. I didn't anticipate the risk would be on the Microsoft PowerPoint side. Yes.
Can I ask more about how you're measuring temperature? You start, yeah?
No, sorry.
So you started off with skin temperature, and in the demo pictures on your slides, you had skin temperature. But firstly, I wondered if there was any value to that, if it was ever useful, or if it was too noisy. And secondly, I wondered, you referred to moving on to body temperature, what you're using for that.
So in both cases, both values are provided by the Vital Connect Vital Patch that is being placed on the chest. The the difference between them is that at the time, the patch that we used was a version that only contains skin temperature. Since VitalPatch have released a new version of their hardware, which now includes body temperature. So the difference is that I'm currently now using one of the newer patches. The older patches are not being manufactured anymore, and therefore you could see the body temperature. If it was useful, I think there might have been a moment where we were considering using the trends on the skin temperature. However, that was discarded as it was providing some confusion to the clinicians, as it's not commonly used, I think, in the setting. So they would, we wanted to avoid them being alerted by a skin temperature of 33%, that they would 33.5, where they would think that is actually the body temperature. So it was better to hide it rather than show it.
So the body temperature, is that actually an estimated body temperature extrapolated from the skin temperature, or is there some second sensor in there?
There are, I think, so VitalPatch have published a paper on this. It's there are two sensors. It's a body. I think it's a differential between the skin temperature and the outdoor or the environment temperature, and they make the calculation based on those.
Thank you. Did you get any? I'm going to hate myself for asking this. Qualitative data on how nursing behaviour changed, or quantitative? Did you put step counters on the nurses to see if now they've got a dashboard at the centre of the unit, do they visit the patients less?
That's an excellent question. We are currently in the process of getting that data and analysing it. However, I don't have any results on that, but we are looking at to see the impact that the system has had on the critical, on the care pathway in the hospital. So one way of observing this is seeing that if the patient deteriorated, what was the next time until the next observation was being taken, for example. Was it a shorter period of time if our system was used, or was it the same as if with patients that didn't use the system? It would be very interesting to find out. And on the qualitative side, interviews now are still taking place with our clinical colleagues.
I mean, I think you can be optimistic about a study that ran for that long, clearly had a high degree of acceptability to the staff as well as the patients. So you can be optimistic about what you'll get, I assume.
I think there will be some good points, and I'm sure there will be improvements to make. And over the course of the past year, we have been constantly getting feedback, and I think there are points for the system to improve. And the only way we can do that is by getting the feedback from the people using it.
Well, hello, Graham. Did you have a question?
Hello. Yes. Hi, Christian. I thought it was a really great presentation. It's really good to see this technology advancing and getting out there. I'm sorry to ask a boring question about temperature measurement as well. So sorry about that. Now, as far as I understand it, there's no clinical standards for this sort of temperature measurement. So I'm looking at the wrong screen. I've got two screens here. There's no standards for those sorts of body temperature measurement devices. So how do they assure? Well, first of all, that must mean they're not assured clinical devices. So are they sold as clinical devices, or are they just as add-ons to what people do?
So they are being FDA approved, these devices, and I wouldn't be able to say specifically if they are clinically approved. We have been, one of the reasons why we're doing the hypoxia trial is to make sure that these wearables meet the standards to be used in the hospitals here in the UK.
Okay. As far as I know, there's no published correlation between skin temperature and core body temperature measured by contact. So I'd be very interested to know or see if there's any published data that this company has on that correlation. That would be very interesting to see, because I've not seen any of that. And obviously there's a glitch somewhere in there, because sometimes it shows 10 millikelvin and sometimes it shows 0.1 millikelvin resolution, which of course is a nonsense. We can only measure to one significant figure. So that ought to be fixed in that glitch. I think Richard's question about assuring the quality of the data and how the actual measurement of the temperature is done reliably, this is a very critical as well. And I've had companies come to me for testing of very similar devices, and it's actually not so easy to do because of the way they actually measure the temperature themselves. So you said there's some published information about that? I'd be interested to see that as well.
Yes, if you send me an email, I will be able to forward you the publications of the company.
Richard has my email address, so please feel free to pass it on, Richard.
So I must say that the temperature wasn't used on the COVID patients, the newer batches with the temperature. So if we're not comfortable in making sure that their clinical validity is good, then we're not outputting.
I would have thought that for measuring trends is probably okay, providing the output of the thermometer is linear. And they're not always linear, unfortunately. But if providing the output of the thermometer is linear over the range of body temperature, then for showing trends, they're fine.
Yes, I think that's what we're focused on now. Yes.
Yeah, but very interesting presentation. Thank you.
Thank you.
So to warn everybody, if you don't stop me, I will use up the last 5 minutes with my questions. So signal by whatever means you can if you'd like to get a question. In the meantime, Christian, would you mind taking us back to your difference plots? You had some Altman and Bland style difference plots, at least that's what we call them in stats.
Yes, just a sec.
I've heard them called Tukey plots, but I could not find the Tukey reference.
So the Bland-Altman plots.
Yeah.
Yeah, this one. Oh, a bit, sorry.
Perhaps I shouldn't have brought the curse of Zoom back into this conversation.
Should be getting there. Here, yes.
There.
Yes.
Yeah, I was struck by the limits of agreement on the known-in for oxygen at the top left there.
Yeah.
That's quite wide, isn't it? I'm not clinical. I don't know how many clinical people we've got here.
It is quite wide. I think if the root mean square error is below 4, it is accepted for clinical use. And I think that's the basis on which we decided on. I cannot provide, I think, more information. I'd have to ask my colleagues specifically on that point.
Am I allowed to jump in here, Richard?
I was hoping you would. Please do.
I think they're quite wide as well. I'm quite surprised. I haven't looked at my recent data very recently, but they look surprising to me. Although, no, they're going to be pulled by those outliers around 80, 85, and those worry me massively. Actually, you've got some big errors around there that I think would be quite worrying potentially.
Yes, so these errors are underestimating what a patient. I think we would be even more worried if they were overestimating and they weren't detecting deterioration.
True.
However, if an alert is triggered because the device is just being overly confident,
True.
I think that's less of a risk than just.
Yeah, so what you've got is something where the patient is at, say, 88 and it's saying they're at 72, for example.
That would be a big difference. That's
which is a
16 point, but that's, let's say, up to 7 points. So they're at 90, but the device says they're at 83 or at 84.
Yeah.
Yeah.
It's a big difference, but I suppose clinically both of those numbers are worrying. Yeah, I do have to say I was surprised by that graph. It's worse than I expected.
So we use pulse oximetry as a teaching example in quite a wide variety of contexts, including clinicians doing CPD courses. And I've had the impression that what they're looking for in oximetry can be quite different in different clinical areas, and that the level of accuracy you need, if you're in a clinical area where you're trying to distinguish 97 from 99, obviously that's very different from clinical areas where it's about catching people before they get to 85. So you said that in general, it's considered usable if the standard deviation is less than 4%. It'd just be interesting to know. I'm fascinated by how these limits get set and whether that's for all clinical areas or whether it's specific.
Yeah, I wouldn't be able to answer the last question. I don't have the expertise. But in general, I think in this case is we're more interested in the trends, and we will be in the virtual HD in general. So if they constantly give a bad reading, then the median would show that in time. But if it's just a temporary because of a probe misplacement, then that probably would be evened out over time.
Well, we've been pushing you hard on questions that you couldn't possibly know the answer to all of them, such as how the skin pack measures temperature and so on. So sorry about that.
No problem. Very good question.
Thank you on behalf of all of us for an excellent presentation. It does feel more than any other of these projects I've seen. It does feel more than any other like this is a glimpse of nursing in 5 or 10 years' time. That it will seem absurd not to have this technology or something very like it. Congratulations.
It's a team effort. I'm just one of the person being here and contributing and here to present. Thank you very much, Richard. It was very a pleasure to share this work with you all.
Thank you for coming, everybody.